Good afternoon, everybody. I understand that one of the sessions was running a bit late and we're still waiting for one of our panelists, but we will continue and presume that she'll join us in a few moments. My name is Patty Solomon. I'm a professor in the School of Rehabilitation Science at McMaster University, and I'm delighted to welcome you here this afternoon for this lunchtime session. It was almost 20 years ago that a small, committed group recognized the importance of the role of rehabilitation in enhancing the lives of people living with HIV. Enter the birth of CAHR, or the Canadian Working Group on HIV and Rehabilitation. And for those of you that were at Stephanie Nixon's excellent plenary session this morning, you would have had a bit of an introduction to CAHR and a bit of an overview as a preliminary for this session today. I believe the founders of CAHR, some of who are in the room today, would have chosen a different name if they would have known that almost 2 decades later, because it has grown to so much more than a working group. From CAHR has grown a cluster of successful researchers and a body of evidence to support rehabilitation in clinical practice. This network has also given rise internationally to include the Canada-UK HIV Rehab and Research Collaborative. So this session today is a sort of a joint session sponsored by CAHR and Kirk. And what we want to do is discuss the role and emerging evidence for rehabilitation in the context of HIV, aging, and comorbidities, and provide examples of rehabilitation in clinical practice for people living with HIV. So we are going to demonstrate the role and evidence for rehabilitation in the context of HIV and aging, and profile some of the evidence on HIV and aging rehabilitation research, to discuss some strategies for enhancing access to rehabilitation, and to discuss some opportunities for new collaborations in HIV, aging, and rehabilitation research and practice. So I'm going to introduce the panel before we start. To my immediate right is Dr. Richard Harding. Dr. Harding is a reader in palliative care at the Cicely Saunders Institute and Director of Global Programs and Partnerships. He has a background in social anthropology, social work, and public health, and worked as an HIV care manager before entering academia. His research focuses on quality of life, outcome measures, and global health. In the empty chair, soon to arrive, we hope, is Stephanie Nixon, and I'll introduce her when she arrives. I think she must have got accosted after an excellent presentation this morning by people asking questions. Next is Chris Lucas. Chris is 51 years old and has been HIV positive for the past 30 years. Chris spent the majority of his life working in the hospitality industry as a waiter and as a cook. This was interrupted in 2007 while he was a cook in a remote, isolated bush camp. He has been disabled since then. Chris now spends his time volunteering at 9 Circles Community Center and hopes that one day he will be employed again. Aging with HIV scares him, but he hopes with advancements in the fields that his fears will soon disappear. Next, we have Darren Brown. Darren is a specialist physiotherapist in infectious diseases, oncology, and palliative care at the Chelsea and Westminster Hospital, the largest HIV unit in Europe. Darren provides both inpatient and outpatient rehabilitation for patients living with HIV and associated malignancies. He leads the specialist HIV outpatient physiotherapy service, which includes clinics and group rehabilitation intervention, the Kobler Rehabilitation class, which provides physiotherapy, supervised group exercise and educational self-management programs. Darren is the Vice Chair of the UK Rehabilitation in HIV Association. Finally, we have Kate Merzen, who has been working in community-based HIV organizations in Toronto for a decade, and has been the Health Program Specialist at the Canadian Working Group on HIV and Rehabilitation for the last 3 years. Kate is engaged in policy change, education, and research with a focus on HIV and older adults. In her current role, Kate provides secretariat support to the National Coordinating Committee on HIV and Aging, a group of stakeholders from across Canada with a shared interest in the assets, needs, and experiences of older persons living with and vulnerable to HIV. So I'm going to provide a very broad context for the presentations that you're about to hear, starting with the definition of rehabilitation. And we tend to use a very broad definition of rehabilitation, and while one might typically think of occupational therapy and physiotherapy, our scope is actually greater, and in addition to OT and PT includes other health and social care providers. We also think of rehabilitation as a very dynamic process. We all know that people are living longer with HIV and experiencing multimorbidities and health challenges that are physical, cognitive, and social in nature. And it's these health challenges that can result in disability and really supports the need for rehabilitation. Increasingly, HIV is also understood as an episodic disability, and Stephanie introduced that term in her talk this morning. This is disability that is fluctuating in nature, and with this fluctuation in nature brings even more complex challenges. So part of the role of rehabilitation then is how to mitigate the episodes of episodic illness and disability, and how to develop strategies for dealing with episodes when they occur. CAHR has long been a leader in HIV and rehabilitation, and it was established in 1998 and has done much advocacy in trying to help health professionals, policymakers, educators, and researchers understand the role of rehabilitation in improving health and quality of life in people living with HIV. So there has been a group of researchers, as I mentioned, that has been quite successful in obtaining funding to further the evidence in HIV and rehabilitation, including one of the first scoping studies on research priorities in HIV and rehabilitation. In 2006, at the International AIDS Conference in Toronto, members of CAHR were able to connect from people from the UK to talk about their advanced rehabilitation service delivery models that they had in the UK. And the UK's strong clinical focus is exemplified through REVA, or the Rehabilitation and HIV Association. We connected with individuals from REVA as we recognized that there could be great synergies in looking at our research expertise in collaboration with their expertise in clinical models of practice. And from that, a different organization was born, the Canada-UK HIV and Rehabilitation Research Collaborative, or CAHR. And I would like to acknowledge Dr. Kelly O'Brien's commitment to making CAHR happen, because if it wasn't with her, I don't think it would have. Through CAHR, we've been able to have 3 international forums on HIV and rehabilitation research, sponsored by CAHR meeting planning grants. In 2013 and 14, and most recently yesterday, we had a very successful day. We've established 3 key areas of priority: HIV and aging, measurement of episodic disability, and evaluating the effectiveness of our interventions. So this was very much a strategic collaboration, bringing countries together with research expertise with those with clinical expertise. Now, before we go further, I just want to give you an example of a case study that we're going to use to have all the panelists refer to put some of the information into context. So I'm going to introduce you to Henry. And Henry may seem very familiar to some of you. Henry is a 60-year-old man who's single, and he lives with his 80-year-old father, for whom he's the primary caregiver. He's been unemployed for many years, but he does enjoy doing volunteer work. He's been living with HIV for 25 years, and he's on combination ART. He has an undetectable viral load and a CD4 count of greater than 700. When you think of his health, when he talks to you, he tells you about a heart attack he had in 2006. He's trying to quit smoking. He does suffer from peripheral neuropathy in both feet and osteonecrosis of the knee. and he's now using a walking stick, or in Canada we might say cane. His main concerns now are pain, challenges in walking, and he tends to be a frequent faller. He's falling on a weekly basis, he tells you, and his fatigue is quite fluctuating in nature. He's challenged with his ability to care for his father, and he's concerned about his forgetfulness. And I'm now going to call upon Dr. Richard Harding to comment on the comorbidities of the case study and the implications of symptom burden and living well in someone with episodic disability. Richard.
Thank you, Patty. So what I'd like to do first of all is put this case study within the context of the epidemiological evidence we have available. And actually this guy may not be quite as unusual as we might anticipate. First of all, this systematic review we conducted of the prevalence of psychological problems of people on ART showed that globally around a third of people who are on ART living with HIV, wherever they are in the world, may have anxiety or depression. And his burden of symptoms, his mobility, his pain also may not be that unusual. We've been running global studies of symptom prevalence around the world in Asia, Africa, Europe. And here's a review of the prevalence of some common symptoms for people with HIV. We're actually a quarter of people reporting problems with energy and tiredness, sleeping, about a fifth of people with joint pain and muscle ache, and general pain almost 20% as well. So he actually may not be that unusual. Also, we've done some work on quality of life amongst outpatients in the UK, showing actually people still do have persisting functional problems. This was data from the Euroqual 5D3 level. 3 level is slightly less sensitive, of course. But actually, people do report functional problems. And also, actually, when we look at his self-report health status, and he's on treatment, we know that, but actually CD4 and ART aren't always associated with self-report health status. So he may not be that unusual, as I said. This guy's had cardiovascular disease, he's smoking, he's got quite a high burden of disease. So what common problems might he have? Breathlessness might be one of them. This is data from a study we've just closed in the UK. This is a man with HIV and COPD. He said to us, the main problem I have is breathlessness, which leads to mobility issues, to social isolation, and generally to sort of hiding away from everyone. So we start to get the sense that maybe what may start as a physical manifestation, a symptom, then starts to lead to psychological problems and social problems. And if we don't take a whole person approach to this person in terms of assessment and management of his problems, we're unlikely to improve his outcomes. Because of my various conditions, I have to juggle 7 or 8 health providers. I have no idea. So again, if we're going to take this guy holistically and understand all of his problems, this could end up being more complex for him, because if you give him multiple health providers, it could end up with an additional challenge for him to juggle. And there's another man with HIV and COPD. What kind of conveyor belt might you end up on unplanned admissions? I invariably go to A&E. They clerk me in easily. I've had excellent care. But if I go somewhere else, they don't have a backstory there. It's hard to go through 20 or 30 years of history when you're breathless. The main symptom I've had is falls, like our character we just described. I have Cushing's syndrome from the steroids and terrible pain and leg weakness. I get stuck in the bath. So again, his care is going to start to become more complex. This guy's going to be able to maintain independence whilst also being a caregiver for his father. And I think that's what put me at suicide risk, this guy told us in London, in the first place, severe worrying. So we can see the sequelae of all of this building up is quite a severe psychological distress for him. So how might we approach somebody like this character we've been presented with? Well, to quote from a colleague of mine at the University of Maryland in the Institute for Human Virology, whenever we present together, she always talks about us moving from the life of the virus to the life of the host, and real person-centered care, which understands the person before us in terms of their spiritual problems, emotional problems, physical problems, and social problems, and trying to take those as a whole. So we really do need to move towards better person-centered care. And as the example of the qualitative data showed, what can happen then is you can have some complex issues with coordination. So we need to consider, if we're going to have complex cases managed through person-centered care, we need to have some real good models of coordination. And how do you prioritise when somebody's got multiple problems? How do we prioritise? How do we work out what matters to the individual? We need to establish what the goals of care are. First of all, for this person, we need to find out right now what matters to you most and what can we manage and what may we not be able to manage in the short, medium and long term. And also in terms of working between multidisciplinary teams, how do we share information and what would the person before us prefer us to do in terms of information sharing? And in terms of working out patient priorities, goals of care, prioritisation, I do believe we have to use person-centred and patient-reported outcome measures to make sure that we deliver the care that is needed and that we're able to measure the effectiveness of that care. It needs to be self-report. We need to be measuring self-reported, person-reported outcomes. And these measures have got to have good content, validity and reliability, because if we don't get the correct construct being measured and we don't have good content validity, we're not necessarily measuring what matters to the patient. And there are some really good measures out there like the MOS-HIV, which actually, if you turn back to the original development and validation of the MOS-HIV, it practically has no content validity. Patients were not consulted in the items of that measure. So good psychometrics is crucial. And we can actually do something with that. So we've developed person-centred outcome measures for people with HIV, particularly in Africa, and moved on to using that approach, assessment and care, into clinical trials and showed that we can really improve outcomes for patients. And we need to think about symptoms. Symptom management is absolutely key to patients. Some problems may seem fairly refractory, like breathlessness. What do? We need to find evidence. We need to approach patient symptoms with an evidence-based approach. A common way for people with advanced disease to manage breathlessness is prescribing benzodiazepines. We did a systematic review, a Cochrane review, found there's very little evidence for that. So we developed this service. And when we talk about having integrated care across disciplines, we really can make this work. The Breathlessness Intervention Service integrated palliative care, respiratory medicine, physiotherapy, and occupational therapy to a one-stop shop. We published this in Lancet Respiratory Medicine year before last. And we found not only did it improve patient-reported outcomes, but importantly, improved survival as well. So there are things we can do. It may sound like a complex task to be person-centred and integrated, but the bottom line for me, the message is that it is possible using evidence-based approaches. Thank you.
Now that Dr. Nixon has seamlessly integrated into the panel, I will take the opportunity to introduce her. Stephanie Nixon is an associate professor in the Department of Physical Therapy in the Faculty of Medicine at the University of Toronto and director of the International Centre for Disability and Rehabilitation. Stephanie is a physiotherapist who has been an HIV activist and researcher for over 20 years, and for those of you who were in the room this morning, we learned some of her journey. Stephanie conducted her postdoc with Professor Alan Whiteside at the Health Economics and HIV AIDS Research Division at the University of KwaZulu-Natal in South Africa. Her current research uses critical social science to explore links between HIV, disability, and global health in Canada and in Southern Africa. In particular, she leads a program of research in Lusaka, Zambia. Stephanie is the social science representative on the CAHR board as well. And so we've asked Stephanie to think about how might we think about HIV in Henry's case from a rehabilitation perspective and the evidence to support rehabilitation approaches to HIV. Stephanie.
Good afternoon, everybody. So the way that we're going to think about Henry and the kind of solutions we want to offer for his problems depends on how we think about the problems in the first place. And many of you know that this is the World Health Organization's ICF, International Classification of Functioning, Disability, and Health. What rehabilitation likes to do is think about the concerns that are happening at the level of activity, participation, and right back at the micro impairments as well, as opposed to putting the focus on health conditions. So if many of Henry's healthcare providers are concerned about his HIV disease and dealing with HIV, what rehabilitation adds to the table is thinking about the kinds of challenges that come to light when we focus on what's happening to his body, what are the challenges he's facing in terms of activity and in terms of the usual social roles he plays. Once we start asking those kinds of questions, it leads to different types of solutions for Henry. When it comes to aging, another important piece of evidence has to do with the episodic disability framework that has brought to light the importance of uncertainty as a disabling concept. So the role that uncertainty plays in compromising the health and wellness of people who may be aging with HIV. So within a rehabilitation paradigm, we also want to be paying attention to uncertainty as a core concept that Henry may be facing and what we can do to help manage this. In 2014, a knowledge synthesis was published by Kelly O'Brien and others that looked at evidence-based recommendations related to rehab for adults aging with HIV. A few that are most salient for Henry's case are the reinforcement of a multidisciplinary rehab approach, number 3, and the 3 at the end, the importance of exercise, of cognitive rehabilitation, and alerting all healthcare professionals, rehab and otherwise, to follow the best evidence for exercise for that individual in the absence of specific recommendations, since there's a huge, huge realm of exercise science out there to guide us. Regarding exercise, there actually is quite good literature. We know that exercise in medically stable adults living with HIV is safe, that it can improve strength, it can improve aerobic function, it can improve quality of life. And in addition to this very little snapshot we've given you of the evidence today, there are 2 resources that pull together all of the current evidence on rehabilitation in the context of HIV. They're open access online, one that's designed for Canada on the left, and one that's designed for Sub-Saharan Africa. Thank you.
I would now invite Chris Lucas to come forward to comment on his experiences in living well with HIV, and specifically how it relates to his experiences with rehabilitation.
Hi, everybody. Is that working? Hi, everybody. Yeah, I've been positive now for 30 years. I tested in 1986. It's been a struggle all the way through. I'm nervous here, so just give me a minute. I suffered a secondary illness back in 2007 that put me in a position that I needed a lot of rehab. Outpatient physiotherapy was a wonderful thing in the hospital. Inpatient physiotherapy was a wonderful thing. Outpatient is another thing altogether. In Manitoba, we're only allowed, with our public health, 12 visits a year. And our physio departments are so busy in this province that they tend to cram all those appointments into 4 to 6 weeks and leave us alone for the rest of the year. My opinion, if there were only allowed 12, then give us 1 a week and follow us through the year. It would be a wonderful idea. But stemming from there, oh boy, I'm nervous here. I'm doing okay? Thank you, yes. Where do I go? My experience is I lucked out with my housing. That was very important with me. With my brain injury, I had a lot of physical problems. I've had to relearn how to live as a left-handed person, and I've lived as a right-handed for my whole life, but the last 7 years, switched over to my left. Housing was important. I made sure that I got a ground floor apartment and that I had hand grips in my bathroom. I was inches away from a wheelchair back in 2007. And I think due to sheer determination, I kept myself away from that chair. I did not want it to be my friend. If it was, my resolve was going to leave. So that chair was just, it was an enemy in the corner, put it that way. So with housing, it's very important that we have a place that we can age with HIV. Those 2 words never went together for a long time, aging and HIV. We now have them, and I guess I'm living proof. 30 years, and I am aging, 51 years old, and we need a lot of direction when it comes to our health care, a lot of support to where we're going to go get it. It's really hard to navigate that kind of system out there when there's so many different options that are not, they're all out there, but it's hard to navigate them, and they need to be put into one spot. I guess that's about it. I thank you.
I'll invite Darren Brown to speak a little bit about rehabilitation interventions that are actually occurring in clinical practice to address some of the episodic disability that people with HIV are experiencing.
Hello, and thank you for having another Brit on the panel here. It's very lovely to be here. So I'm another physiotherapist as well, and I'm very lucky. I work at the Chelsea and Westminster Hospital in London, which is the largest HIV unit in Europe, and we have a really specialist outpatient HIV physiotherapy service, which I'm going to tell you about. So basically, it combines two key components. So the first is our one-to-one HIV specialist physiotherapy clinic. So that's basically a half-day clinic where I can see people for 2 days. They'll come and see me either on a Thursday or Friday afternoon, and I can either provide them with one-to-one intervention, I can advocate for them to receive local rehabilitation services nearer to home, or I can refer them into other services, for example, community occupational therapy, speech and language therapy, or in fact it may be that they require an inpatient stay at a rehabilitation unit and I can refer them to there. A lot of my role in that service is actually around advocacy. It's about supporting people to access rehabilitation. The other part is actually our group rehabilitation intervention, the CAHR rehabilitation class, and I'll tell you a little bit more about that in a second. But what I want to talk to you first about is who accesses this service. It's quite a small service, so we only, over the 2-year period, we did a retrospective audit from 2013, and there was 137 patients that accessed this service, and as you can see, the median age of people that are attending is 52. So people are aging that are attending this service. We also know that 83% were male, 80% had been living with HIV for longer than 10 years, and 97% had an undetectable viral load. So on paper, people are aging and potentially living well with HIV. However, people that come to this service are predominantly inactive. They're not meeting the UK recommendation guidelines on regular physical activity. They're living alone. They're potentially living close to the hospital, maybe indicating the amount of services that they're acquiring, and they're unemployed. We also know that they're living with, on average, 5 additional comorbidities. And 87% of our cohort are defined as complex comorbid. So what that means is living with 2 or more long-term chronic conditions in 2 or more different body systems. For example, living with HIV, living with COPD, and living with osteoporosis. Now what we did was we used the Eurocol EQ5D50, and Richard mentioned this data earlier about the presence of impairment that's self-reported by people. And it has 5 key domains. So it looks at mobility, self-care, usual activities, pain and discomfort, and anxiety and depression, and it's a self-reported measure. What we did is we looked at who presented to the HIV physiotherapy service and their self-reports in comparison to HIV outpatients in the United Kingdom and the UK general population. And what you can see here is that across all of these 5 self-reported domains, people accessing HIV specialist physiotherapy have significantly higher self-reported problems and functional impairment. It also gives us an index value. And its index value pretty much doesn't mean anything, it's just 0.44. But what it does mean we can do is we can compare it to other health populations. For example, we can compare this to older adults at risk of hospitalisation and mortality in Europe. And what we showed is that actually our index value indicated that it was worse than elderly adults in Europe at 12-month risk of hospitalisation. And it was nearly as bad as 24-month risk of mortality. So what does this tell us? This tells us that we're probably dealing with a bit of the tip of the iceberg here. The majority of people that are accessing this service are living with complex comorbidity as they're aging, and they have functional impairment, and potentially could be classified as frail because they're at risk of hospitalisation and health service utilisation. Now, in those patients that received one-to-one physiotherapy, what we showed is that actually there were significant improvements in mobility, significant improvements in ability to perform usual activities, significant improvements in pain and discomfort, significant improvements in anxiety and depression. And what we also showed is that people that received one-to-one physiotherapy in the clinic also reduced their index value that reduced their risk of hospitalisation in comparison to older adults across Europe. Now, we also mentioned we have our group rehabilitation intervention called the CAHR Rehabilitation class. So this has been developed specific to meet the needs of people living with HIV and using all of the evidence that's available to us about exercise. So it's a twice-weekly supervised group exercise program led by physiotherapists that combines cardiovascular exercise, progressive resistance training, neuromotor exercises, so that's balance, gait, coordination, flexibility training, and guided relaxation, which is a bit of plinky-plonky music and me guiding people through how to relax. Now, we also have our self-management program. So what this is once a week before we exercise, for about half an hour, 40 minutes, we have a group discussion about living with HIV as a long-term condition with invited experts. It's not didactic teaching. What it is it's the collective need of the group that drives the discussion around all of these different topics. Has this got a pointer? No, then I won't point. You can see. So we go through a lot of different topics. So for example, with our dietitians, we talk about healthy diets. We do fatigue management with our occupational therapist. With our advanced nurse practitioner, we do living with HIV. The opportunity is a one-stop shop to ask the questions that you need to ask because maybe you're too afraid in other opportunities or you only get 5 minutes with your consultant. Our sleep physiologist does a talk around sleep issues, and our psychologist does a session on body image concerns. We have community organisations such as Living Well and Positively UK that come in to talk about what other services are available to people in the local area. We also do stop smoking services, and also we have community exercise services that come in. So for example, in central London, we've got the YMCA that does a positive health programme, which is a 12-week exercise programme. And some people use our service as a bit of a stepping stone because of the disability that they face and the fear that they have about accessing a gym, for example. They use it as a stepping stone to maybe go back there. But we also get the local leisure centres, because in the UK we have GP exercise on prescription schemes, which means that people can have subsidised memberships to local gyms if they're living with a long-term health condition. So we get those local leisure centres in to tell us about that as well. Sessions with our health advisors about intimacy and relationship. Psychologists do 2 sessions, one on goal setting and then another one about how to overcome our barriers if we don't achieve our goals. We do one with our palliative care doctors or symptom control doctors on pain management, and then lastly, we do one on stress and relaxation with our occupational therapist. Now, when people come to this service, we use a whole raft of different outcome measures. We look at height, we look at their weight, we look at people's body shape, we look at people's resting heart rate, and we look at people's locomotor performance, which basically means the ability to walk. So we use a 6-minute walk test. We get people to walk up and down for 6 minutes and see how far they can walk. We also look at their strength of their upper limb and their lower limb, and we also use the FAHI, which is the Functional Assessment of HIV Indices, which is looking at health-related quality of life. We look at flexibility, and I think most importantly of all, we look at people's goals. We use the GAS goal system, goal attainment system, which is basically, what do you want to achieve by coming to this rehabilitation service? What is your goal? Now, we measure all of these things at week 0, and again 10 weeks later. But this service has been modelled on the episodic disability framework, in which we know that only 46% of our patients can actually adhere to this programme, and adherence is classified as attending 8 or more out of 20 sessions. So we have a drop-in service, so that actually people can attend, return, or restart, depending on their fluctuating health challenges. And we have embedded flexibility into our service. So either you can come back to the one-to-one clinic, or you can go back to the class, depending on what your health needs say at that time. These are goals that people set. So for example, body image is one of the most common goals that people set, as well as participation, health and fitness, and improving their mobility. Now, when we look at the outcomes of people that attend the programme and we complete the measurements again afterwards, locomotor performance significantly improves by 86 metres, which actually exceeds clinically important differences for things like COPD, heart failure, community dwelling older adults, and stroke survivors. Strength improves in all muscle groups, upper limb and lower limb. Health-related quality of life improves in physical well-being, emotional well-being, and a trend towards improvement in functional and global well-being. Flexibility improves by 8 centimetres. But I think the most important of all is that 64% of people achieve all of their goals, and on average, people are setting 3 goals. So if we're thinking about Henry had mobility problems, and actually, if we kind of think about who's coming to this service, I would say it would be Henry. Henry's having problems in lots of different domains of his life, and actually, he could improve his mobility, he can improve his strength, he can improve his quality of life. He might even be able to achieve his goals. But we also need to think about, how do people access these services? Are these services uniformly available to people? And the answer is no. And if we're thinking about people aging with HIV and potentially presenting with frailty that may be at risk of greater health service utilisation, could rehabilitation be a way of reducing health service costs and supporting people to live well and live independently when aging with HIV?
Thank you, Darren. In Canada, we're all really quite jealous of the UK models that they have there, and I know that Chris really highlighted some of the challenges that we have here in Canada and in Manitoba in terms of access to rehabilitation. And Chris Merzen is going to come and talk about some of the challenges to access to rehabilitation and about CAHR's role in advancing access to rehab.
Hi, everybody. So my role here today is to think about how all of this plays out in the Canadian context and to talk a little bit about the work that CAHR is doing. But I wanted to title this portion of my talk, "The Time to Begin Most Things is 10 Years Ago." I think that if we had the foresight to respond to things before they became critical issues, especially in the world of HIV and aging, we might be in a little bit of a better position. So the first thing that I wanted to say is that unfortunately at the policy level, Henry, the whole person that Henry is and all of the needs that he might have, is relatively invisible. So different aspects of his identity as an older person, his identity as a person living with HIV. We don't know much else about Henry from the brief case study, but some of those aspects may be addressed through certain policy responses, but his whole personhood is not visible much in those policies. We're lucky insofar as the Public Health Agency of Canada and within the health context, there's starting to become an increasing recognition of HIV and aging as an issue unto itself. But we don't see that reflected in policies around housing necessarily, in policies around social supports for older adults who may not yet be the age of being seniors. And what we see is that we don't have a national seniors or aging strategy at the moment. We have an outdated HIV strategy, and chronic disease management strategies, which happen at our provincial levels, make an explicit, and I would say faulty, divide between HIV and other chronic health conditions. The ones that do mention HIV within them, I think there are two. They sort of position people living with HIV as more of a liability than a target for support in health policy making. And that's a problem because we do know, we've heard about self-management supports, and we do know that people aging with HIV need the same kinds of services available to them as people living with other sorts of chronic health conditions. The other thing is we have no national rehabilitation strategy, which results in the fact that many people who need access to rehabilitation don't have access for a variety of reasons, cost being one of the major ones. So, on a happier note, I want to talk about some of the work that we're doing to respond to these gaps and challenges. So, CAHR is so proud to be the Secretariat for the National Coordinating Committee on HIV and Aging. Many of my fellow NCC members are in this room, so hello to all. And what we do is we bring together stakeholders with a shared interest in the assets, needs, and experiences of older adults who are living with or vulnerable to HIV. Our functions range from awareness raising, like the social media campaign we did on HIV in older adults in the lead up to World AIDS Day last year, to knowledge translation of all your wonderful research to the community, but also to frontline service providers. And first and foremost, I think the idea behind the National Coordinating Committee is about cross-sectoral collaboration, bringing together folks who may not have worked together from the aging sector, the HIV sector, chronic illness sectors, and saying, how can we work together to respond to the needs of older adults? Another initiative that we're currently working on is the Pan-Canadian Equitable Access to Rehabilitation Network. I know that's a mouthful, we're working on the name. But this will bring together stakeholders with a shared interest in ensuring that people have equitable access to rehabilitation services across Canada. Right now, our access is very good if you suffer an acute illness or injury, but it's not very good if you're suffering from a chronic illness and you're usually deprioritized or put on a wait list for a long period of time for outpatient services. And so the goal of that group will be to come together and look at ways that we can tackle those barriers. So the questions that remain outstanding are many. The first one, which comes up in a bit of a different way in HIV and aging than it tends to come up in other areas, is the issue of HIV exceptionalism versus integration. And so we think about people aging with HIV dealing with massive amounts of comorbidity and dealing with a lot of complexity in their health. And chronic disease management programming may be equipped to actually help people dealing with multimorbidity better than HIV-specific services. People are wanting to have safe environments in which to access service, but we also need to balance making sure that those spaces can also address all of their needs. And it may be time, and I don't purport to decide this, but it may be time that we work better in collaboration with other organizations who are dealing with lung health and cognitive health and other services, because HIV services may not be equipped to do it all alone. The second thing is we're implementing creative solutions with existing resources. So we're collaborating with Kelly O'Brien on the YMCA community-based exercise study to see how we can increase access to exercise programming for people living with HIV. We have occupational and physical therapy student practicum placements in frontline HIV organizations that are exposing both the community and service providers to those services. And finally, we're working on a project called Working Together Across Canada, and this is a service provider training for folks from both the HIV and aging sectors, all about the needs, experiences, and assets of older adults living with HIV and what care and support they need as they enter aging sector services. So whether that's long-term care, home care, seniors supports in the community, we really want to make sure that for someone like Henry, those services are well equipped and understand his needs, both social, physical, and emotional. That's all for me.
So I must admit this is a first. I told the panel that they were to leave lots of time for questions and to be succinct, and they all were. This really is a first for me. So we do want to have some questions. Just in summary, Richard talked about the complexities of the comorbidities and the symptom burden when aging with HIV. Stephanie touched on some of the evidence for rehabilitation and our evidence-informed recommendations for older adults in rehabilitation. Chris very eloquently talked about his experiences and some of the gaps in care for him as he lives with a disability and ages. Darren presented his very envious program that he delivers in the UK. And Kate talked about some of the challenges to access. And so now I'd like to invite you to ask questions of the panel so that we can further your understanding of HIV and rehabilitation.
So I think I'd like to start my question to the extraordinarily wonderful Stephanie Nixon and ask if I might encourage you to revise your slide where you had health conditions and then sort of divorced from rehabilitation, or not quite linked to rehabilitation, to understand this idea of how integration works a little bit better. Because to me, the Henry case, he's, to borrow your term about episodic disability, he's the most at risk for what you might call episodic immunological or virological failure from non-adherence, delinking from care, loss to care, and needs to return to care. And so that first assumption is very, very fragile and in need of rehabilitation itself. And in that regard, besides having the connection between or among all the providers, is the idea of how to prioritize the kinds of rehabilitative services that he needs. Certainly, I don't think you would disagree to prioritize smoking cessation among those things. So that's not a question, it's a comment, I guess.
Thank you, Robert, for that. I agree completely. One of the things they try and do in that schematic, it's a World Health Organization framework, is to have double-ended arrows. And there was an earlier rendition of that same schematic that had single-directional arrows, as if things happen in a particular sequence. You start with a diagnosis, it causes impairments, it leads to activity limitations, and those things compromise your social roles. What they did in the evolved version is to have bidirectional arrows to suggest that these things happen in all directions. It's complex. It's moving at all times. So in addition to your helpful comments, Robert, that's my addition.
Yes.
Yeah, hi, this is wonderful, thank you. As a long-term survivor, with multiple comorbidities. Besides moving back to London, which sounds like a really good idea right now, the biggest challenge I face, I'm an executive director of an ASO. I've been working in the movement since 1989. I'm well connected. I know who the players are. I know how to get treatment. I have 11 physicians I have to see, and I have to go to Toronto to see most of them, and they don't talk to each other, and it's really hard. And I went through multiple surgeries and couldn't get rehab, and I certainly couldn't get it in my own community where I live. And so the challenge is huge and compounded by geography, not just availability of services, services that don't talk to each other. So I love that this is coming and happening, but more power to you. But there's one thing I wanted to ask that no one actually addressed on the panel, that in Henry's little bio, it mentioned he was the primary caregiver to his 88-year-old father. Well, I can relate. My mom has Alzheimer's, and I'm coping with that. And she's healthy as a horse. I have brittle bones. I've had 3 operations for various cancers. You know, I'm a mess compared to her. But she's rapidly losing her mind, and I got to take care of her. And so the impact of that is also compounded by the fact that my friends who survived with me are now no longer surviving. I've experienced personally 4 losses of long-term friends who are living with HIV for 20 to 30 years like me. And it's I know my resilience, but the impact, the emotional impact of these losses, not just of parents, but also of peers, it's profound, and that wave is coming, right? And I don't know if we as a movement are prepared, and I certainly know that the clinical side and the rehabilitation side is not. So are you guys, is that on your agenda, is my question. Sorry for taking so much time.
Who would like to tackle it? You want to talk about the access, Kate?
Well, is this on? Yeah. I actually want to talk about a little bit about the end of life stuff that you brought up, so thank you for doing that. It's definitely on the radar at QIGR, and we're starting to think about how we at QIGR, but how we can also work with other partners to support people emotionally through that process, but also supporting them pragmatically in helping them prepare, thinking about their values for end of life, especially people for whom this is not the first time they've had to consider those things. And thinking about how we can increase healthcare consent and access to healthcare consent across the life course for people living with HIV. So that's one small part that we're doing, but you're right, the emotional aspects are going to be really salient in terms of how we respond to the issue of multiple loss again, or continuing from the early days.
I think your point is, am I on? Yeah. Your point is absolutely crucial to where we move now in models of care. My view is we're a bit stuck in a kind of very medicalized pre and post ART model of understanding people living with HIV. When you look at people who are dying with HIV, we are still stuck in a language of, is it AIDS defining? And actually, people aren't dying of AIDS-defining illnesses now. They're dying of HIV-related illnesses because they are more common amongst people living with HIV. But that's not understood. If it's not AIDS-defining, people don't see the connection. And I think our models need to get less medical, more person-centered, and more recognizing that we're not in this AIDS-defining, not AIDS-defining era anymore. And we need to catch up with our thinking and our language.
Thank you.
Just like to comment that in one of the models that I've developed, that looking at some of the challenges in aging with HIV, and it builds on Kelly O'Brien's work on the episodic disability model. This uncertainty that you're talking about is at the core and the center of some of the disability people are experiencing. And what you're talking about is this uncertainty related to caregiver burden of your mother, losing others, and so on. Very important. Yes.
Thank you for a great panel discussion. I really enjoyed it. I'm Laurie Ringart from Winnipeg. And I guess I was excited to hear about the direction that you're talking about for Quigger, and looking at policy was one of the things. One of the things I'd like to encourage, thinking of the ICF again, is looking at the environmental factors piece of it. And one of the pieces, and I mentioned this yesterday, was that we have to look at policy around housing in terms of what's called visitable housing. And visitable housing policy is that we build all new housing with a no-step entrance, wider doors, bathroom on the main floor. And this is a movement that's going on. Those of you that are from Britain know about it quite well. And we have to look at those broader policy things. But I just encourage the HIV movement to take that on, because that's the way to go. Instead of just looking at specialized housing, looking at an integrated model of housing. So anyway, I don't know if you have any comments on that.
Just to say that I know that folks in BC are experiencing the building of a new facility, hopefully many of which the units will be designated for people living with HIV. And I know that one of the concerns that they came up against was that the plans didn't seem to demonstrate accessible units. And so that was something that they really advocated for, understanding that most of the people who will eventually occupy those units are going to be folks who are living and aging with HIV and who may benefit, but also, as you're saying, their friends, their family, the people who also enter the building will benefit too. And that's about universal design. Right?
Other comments, questions? I know you have some. Right here. Over here?
There's a couple of people waving at the back there.
It's a big room.
Hi, thanks for the presentation. In terms of when it first started off, there was a lot of talk about anxiety, depression, and cognitive rehabilitation. I'm just wondering, in terms of, I guess, one in the UK model and as well as in our model, how that fits in terms of strategies and access to mental health support and rehabilitation, and if there's any directions in terms of where we're going in that perspective.
Darren, do you want to talk about your model?
Yeah, thank you. Great question. I think the first comment I'd have on that is actually the role that exercise plays, not only in managing a lot of mental health issues, whether that be anxiety and depression, but also the role that, and the evidence that's coming out around the role that exercise can play in supporting people with cognitive impairment. There's some lovely stuff coming out from Ireland with some of the colleagues from Kirk, specifically looking at the improvements in cognitive function with people that participate in a 16-week program of exercise. I think that, for example, in our model in the UK, we don't actually have cognitive rehabilitation integrated in. We do have access to occupational therapists, but even within our own model, we still have limitations and restrictions, and that's something that we've identified and we would like. But actually, that's about having access to staff, having resources available, and even within our context, where it may seem like we're incredibly resource-rich, we also still have those limitations, and we don't have access to outpatient occupational therapists that would be able to provide that.
I'm going to pose a question now to the panel then. It was highlighted upon by some of you, but I would appreciate some more comments about the importance of an interprofessional and interdisciplinary way of practice, as alluded to that gentleman over there. He sees multiple practitioners who may not necessarily communicate with each other. So I would invite some comments about, as we transform into HIV into a chronic illness, the importance of interprofessional ways of being. So. Go, Darren, go.
Me?
Yeah.
I think from my own personal experience with interdisciplinary models of care, I feel that the biggest thing is actually the level of accessibility that people accessing services get from that. So for example, because people come to my program and we have the self-management program where we have so many different health professionals that are coming in and discussing about certain challenges and living hopefully well with HIV, it enables people to be signposted to different services and different professionals that maybe wouldn't have necessarily been on their radar. And so I think actually it's really important that we do enable people to be signposted and we do work professionally, but also we empower ourselves to know what other health professionals are doing so that we can provide that information, because not everybody is aware of everything. And so I think actually that's something that's very important about interprofessional working, so that we make sure that we are all working together for the prosperous well-being of people living with HIV.
Chris, do you have any comments on that?
And I don't think so.
Okay. You want Kate?
I'm only going to comment on it from an access perspective, and sometimes we're finding that the push for interprofessional teams in healthcare is actually an opening for us to have free or low-cost access to some of these services for people aging with HIV and living with other chronic health conditions. So for example, in Ontario, we have a family health team model, and that family health team model allows primary care physicians to work in the same setting as nurses, nurse practitioners, pharmacists. They also have the ability to bring on board, dependent on their patient population, rehab professionals, physiotherapists and occupational therapists, as well as mental health workers and social workers. And so I think we see that as an opportunity at CAHR about how we can build on what's already happening in the health system to expand access to those services, whereas someone who doesn't have access to a family health team may not be able to access those services for free in community. So I can't speak to interprofessional practice. I'm not a health practitioner, but that's my take on it.
Thank you.
I think we've all got friends with complex health needs whose lives seem to be taken up with their diary being full each week of appointment after appointment, day after day, going to different professionals in different buildings and waiting for decisions to be made after letters are followed up. So I think the idea of interdisciplinary and I see a nod over there, a multi-professional working is absolutely the right way forward, but it can also bring a great burden of healthcare attendance to people. So we need to think about that very carefully. And some of the data I shared with you from the people we've been talking to in London talks about the utter exhaustion of repeating their stories over and over again to numerous professionals. So we need to make sure that the multidisciplinary and interprofessional model serves the patient rather than challenges and taxes them. And there are some examples of how that works. So I showed you the breathlessness intervention service where we bring all the professionals to the patient, and Darren's Kobler class where it's a kind of rotating model where the patients are there and the professionals come in, which may also have a kind of health economic argument as well, because you've got professionals coming in to see numerous patients at once, so there may be some cost effectiveness there. So multi-professionalism should serve, not challenge the patient, would be my only comment.
This question.
Hello. My question is from our friends from the UK. Thanks for coming all this way. I apologize if I missed it. I'm not sure if you were both around for the inception of Darren, for instance, your program, but could you tell us about some of the key challenges that were faced, maybe on a policy level, which Canada might take better note of so that we can avoid those pitfalls going forward with a model like yours, which sounds fantastic?
Thank you, great question. So the inception actually, so I started working in the position about 5 years ago, and prior to me starting working in the trust, there was an exercise program, but my position was vacant for a very long time before I was there, and so actually it kind of just disintegrated. And so when I started the trust, I re-established what was previously an exercise program, but then added on the self-management program. And the reason I did that is because we know with other chronic long-term health conditions, so for example, pulmonary pulmonary rehabilitation for people with COPD or cardiac rehabilitation for people with heart failure. We know that they combine both exercise and education that's specific to the needs of people with those health conditions. And so I felt, rather than reinventing the wheel and trying to create something new, well, let's just create a model that we know works for long-term health conditions, which is combine exercise and education. And we know that those other models not only improve health-related quality of life, improve or reduce health service utilization, and are cost-effective and clinically effective. Well, what I'm hoping is that actually we can prove the same thing in this model in a different healthcare condition. In relation to kind of like the policy challenges that we faced, I think it's a very UK-specific issue, but it's actually around the funding. It's actually very difficult to find out where the money comes from and where the money goes. That's something that we have repeatedly tried to find out. Obviously, we're in a changing landscape of healthcare, and actually one of the things that Richard mentioned around person-centred care and multi-professional working and almost that one-stop shop of refractory breathlessness. In fact, we're seeing in the UK that we're almost moving away from those models because actually people, health service utilisation or health services can earn more money by lots and lots of different health visits to different health professionals, and so actually the idea of one person going to see 6 professionals at one point is actually being disintegrated almost. And so I think that that's one of the things that challenges we're going to face in the future, which is about how we make sure that we are empowered to support and understand the importance of person-centred care, providing multi-professional working, providing services that work for people, that have been developed with people that are using those services, because they're cost-effective and clinically effective, and they're the things that we need to establish.
Thank you.
I have another question then that I'll pose to the panel. I have lots of them. I want to talk about self-management programs. And given the challenges with access that Kate alluded to, are self-management programs a way to go? Or where do they fit? And is this just really putting the responsibility back to the person living with HIV? I'd like to get people's reaction to that. I didn't prepare them with this one, so.
I think, if I go first, I think you're right that self-management could be seen as a risk of task shifting and cost saving. However, there is also an argument. We're doing some health-based programs in Europe at the moment. We're doing a 7-country study with around 7,000 people living with HIV to see if you can put a self-report outcome measure on an app and lead people to how to self-manage if you can improve people's outcomes. The important thing is you've also always got to have some kind of alert system with scores that if somebody's problems aren't being managed, they seem to be getting worse, that there is a clinical alert, and also that you've got an immediate route back into a face-to-face encounter. So I'm kind of for the idea of patient activation and kind of self-management, and there are some nice clinical trials from the US of self-management for symptoms for people with HIV. But I think it comes back to me to the importance of patient-centered and patient-reported outcome measures so that you know if somebody's not doing well or if something's not working, that you've got an immediate alert and there's a clinical response.
Well, I know personally as a patient, I thrive better when I know other people out there helping me look after myself. And I think most of us that are in that position are like that. To self-manage ourselves, we know what we're supposed to do, but to get that message across to people, it's pretty difficult. So when other people are out there helping you navigate and work the whole system, that helps us be stronger with our own recovery.
Patty's giving me the eye, so I guess I better comment.
Giving everyone the eye.
So I think that it goes back to equity, and I think that it depends on the person. Some people want to be very engaged in their care and want to take an active role and want to self-manage, and those people should be given every tool and resource to be able to do that. Other people are not in a position due to other things that are happening in their lives, and we realize that sometimes those things are very complex, that isn't their focus at the moment. They want to go to their healthcare provider and they want some clear direction or recommendation about what they need to do at the moment about a particular issue. And so I really think that direction has to come from the person.
I think it depends on a hierarchy of need. So, for example, those people that need the most will probably not benefit so much from the whole process of identifying self-management. It's almost putting the burden on the person. And I think that that's where services like, for example, what we have at Chelsea with the COVID rehabilitation class, those people that are accessing that service have the most disability, have the most need, have the most impairment, and so therefore require those services. But then there may be other people that don't necessarily require that level of need at the kind of different end of the spectrum. And I think that those people may be able to utilize things like health technology, mobile apps, etc., to find the information that they need to do the things that they need to do to self-manage that at that time, but then knowing that maybe if their need changes, that there are service provisions that can provide you with the need that you have at that time.
Other questions from the audience? It's a very quiet audience. We'll move on then. Going back to Henry. And thinking about what some of the roles of rehabilitation could be. And you can see, there's a lot on this slide, but in the center you can see physiotherapy and occupational therapy. And we've highlighted these two professions, but I think we've also made it clear that rehabilitation is much broader than that and includes many other health providers. So for physiotherapy, thinking about cardiac rehabilitation, bone and joint interventions, looking at interventions to increase mobility and activity, reducing pain and numbness, decreasing the falls risk. So lots of opportunities there to help Henry deal with some of his disablement. From an OT perspective, cognitive rehabilitation, vocational rehabilitation, looking at how his social network can be expanded and helping with that, and helping deal with the caregiver burden that he's encountering. I'd like to talk a little bit about some of the next steps. Kirk has actually grown from a few individuals who actually went over to London a few years ago and tried to think about how we could build partnerships, to having a much more broader international network. And so we're looking at how are we going to transform Kirk that's beyond a Canada-UK collaborative to more internationally as we look at the role of rehabilitation in management of HIV illness. I think the other area that we are really going to be working at is thinking about developing clinical practice guidelines. We do have evidence-formed recommendations that Stephanie referred to, but we really need to build the evidence, particularly related to the effectiveness of interventions, and think about developing clinical practice guidelines for the clinical community so that we have strong evidence to support and continue to have strong evidence to support what we do in terms of rehabilitation interventions. So I would like to acknowledge Kirk, CAHR for having us here today and sponsoring the lunch, and CIHR and QIGR for supporting this session today. I would invite you to come and talk to the panelists. We have a few minutes to engage in some more informal interaction and allow you to get on to your next session. So thank you for your attention to this afternoon, and have a good afternoon. Thank you very much.